Dr. Hassan is on the Canadian Muslim Mental Health Conference Organizing Committee and has been on the committee since the very beginning of the conference. He is an addiction psychiatrist and a clinician scientist at the Center for Addiction and Mental Health. He is also an assistant professor in the Department of Psychiatry and the Department of Pharmacology and Toxicology at the University of Toronto.
Tom, are you?
He completed his psychiatry residency, mood and anxiety fellowship, and addiction fellowship at the University of Toronto. He is a fellow at the University of Toronto. He completed his fellowship at the University of Toronto, and he is a fellow of the Royal College of Physicians and Surgeons of Canada and a diplomat of the American Board of Psychiatry and Neurology. He also completed his master's degree in public health from Johns Hopkins School of Public Health. He has a particular research interest in the biopsychosocial aspects of addictions, as well as spiritual aspects of addictions, improving the care for patients with concurrent disorders with a focus on patients with both substance use disorder and stress-related disorders. So with that, welcome. I'm going to hand it over to Dr. Hassan to take us away for this exciting talk.
Thank you, Arfine. Can you hear me? Okay.
I can hear you great. Thank you.
Okay, great. And I think you can see me well as well, right?
We can see you great. Yep. And we'd just like you to pull up the slides whenever you're able to.
Absolutely. Can you see my slide now?
Yes, we can. Perfect.
Okay, perfect. All right, so earlier I had like the picture was frozen. So if that happened with me, please let me know, and I'm very happy to repeat myself again. It's no problem. I understand that like we can't really fully depend on the technology, so just let me know. Okay, I'm very delighted to be here and speaking with you again. This is obviously a large topic. We have an hour to cover it, but obviously an hour is not enough. So I will be focusing on a certain aspect of it. And as just like Arfine said at the end, I'm happy to answer any questions you have. I'm sure after we presented this version of topic to different venues, and including mosque and even for medical school for students. So there's always questions and queries, and so we'll try our best to make it as beneficial and helpful, and hopefully we can answer some of the question or get some of the ideas. So to start with, this is the objective that we decided, or at least the panelists for this year conference thought that it might be interesting. So we're going to explore addiction as it relates to the maladaptive coping mechanism. So obviously, is it related to how we deal with our stress, social stresses, psychological stresses, and then we're going to discuss biological causes. So I'll be focusing more on the biological causes, but it's very much related to the psychological causes and also the social aspect as well, and the development of addiction. Actually, I'm going to tell you more about the development of addictions from a biological view as well. And then we're going to define addiction overall. They wanted me to focus on the behavior addiction. I'm happy to do that. They're pretty much the same almost as a substance use. So I'm going to tell you more about that. You might be surprised by what I'm saying right now, but we will let you just stay tuned, because it is actually a brain disease. And then, yeah, so this is my really hot topic of research. So when we say biopsychosocial, we mean the biological, obviously, and the psychological, and the social, and the spiritual contribution to how we approach it in terms of treatment. But there is also the biopsychosocial of how the addiction can develop. So this is also an area that we need a lot of more research into it. So I will introduce what we know so far from literature and from reviews. Okay, all right. So I think we should start with a poll question here. I just want to know who's in the audience more who would be beneficial. And as Arfine mentioned, there will be a lot of poll questions, an interactive one. So hopefully it won't be as boring. So I think, are we doing the poll question right now?
Yes, we are, Ahmed. Just give me one moment. It seems like the poll questions just might take a second.
Okay, okay, sure.
There we go. Should be able to see them now.
Yeah, we do. That's poll number 2, I guess. So I think we should go back to poll number 1.
The poll question that I have is, what do you hope to learn from this session?
Okay. It just says Dr. Hassan poll 2. So I thought
Yes,
that was,
yes,
all right,
yes.
that's fine. We can start it. Okay. All right, so take a second and answer the question. It will also help me to address or to state longer with areas that you're interested more in. But we are going to cover most of it.
So I've shared the
All
results
right.
now.
Okay. Yeah, as I saw, the biopsychosocial and spiritual aspect. Okay. All right. And then more exploring the addiction is maladaptive. And then, yes, the definition. Okay. All right. So this is basically, again, so to match the objective, we're gonna we sorted the outline in terms of questions. So we tried to answer what is addiction, what causes addiction, what are the protective factors of addiction. So this one, we're gonna tell you about, but there's a lot of research out there in the protective factor, and it's really on, it depends on the individual, it depends on the community, it depends on the social factor, it depends on childhood factor, it depends on a lot of stuff to protect it. There's a lot of research still, and we need much more in research to answer this. But we're gonna give you a generic theme of what can be helpful to protect from addiction in general. And then we're going to try to answer what are some common types of addiction, what are the effects of addiction, and how is addiction treated, was a really big, also a big topic. But we'll try to give you also the overall map, as they say, of how we usually approach it and how can I help someone with addiction. All right. Okay. So I'd like to present these. Well, I have 2 cases. This is actually from my clinical practice. And they're very much related to what we're going to talk about, especially to the maladaptive coping mechanism. So there is a MSK, obviously it's anonymized, like there's no identification data here, but 45-year-old woman who has 3 children and works. 2 years ago, she was diagnosed by actually me with sedative use disorder. So that's sleeping medication, and she got dependent on it, physically and psychologically. So we call it sedative use disorder. But we also diagnosed her with anxiety. So anxiety is a general umbrella. There's different disorder falls underneath anxiety, and she has 2 types. Social anxiety. This is when you have a lot of fear from negative evaluation or criticism, which drive you to avoid certain social settings. And then there is the generalized anxiety disorder, when you basically become very much a warrior. You worry about multiple things, and you always exaggerate, and you expect the worst outcome. So anxiety by itself is not a clinical disorder, but when you reach to certain areas that the anxiety is too much, that's we define it in clinical, and it can affect the person function. So she was treated from the sedative use disorder. We were able to treat her from the sedative use disorder, and in the anxiety, she kind of refused the medication back then. That was 2 years ago, and she was doing good for about a year and a half. Just 7 months ago, with the start of the COVID, there was a lot of stress. So a job, they assigned her a job that she was not, a job rules that she's not happy with, and she did not like. She saw that job is she had a lot of free time. They're not using her best skills. So that was a big problem, lots of free time. And then obviously the stress of COVID and the lockdown, the kids are out of school and at home. So all of that was cumulative stress all at the same time. So that triggered her to go back to the sleeping medication and use them more than she likes to. So losing control, back to a disorder, meaning another way being dependent on it. But then quickly, the problem escalated. A lot of people interfered. from her life to help her. They were able to put her in rehab. Um, she was able to stop them again, but then she came back to my clinic, and she was very fearful of going back. She wanted more help and resources. What struck me is she said something. She said this is a quote from her. So when I stop, or when I stop the sleeping pills, or when I'm sober from them, when I don't use them, I keep distracting myself. But I'm overwhelmed. She's overwhelmed from approaching treatment. She's been really approaching multiple treatment from physician, social worker, rehab, meetings, all of that. So you can see, like, what do you think she's distracting herself from? So if you're guessing that it's distracting herself from anxiety, that's right. So it's she the anxiety is still a problem. That's the psychological stress. Well, and here she's overwhelmed because she's trying to use a lot of it. That's a lot of coping mechanism to cope with it. Earlier, she did use the sleeping pill, but now she realized the problems, and people were really, like, all her family stood next to her and realized that this is kind of stuff. So now she's engaging in something else. So I gave this example because I want you to see, like, if a person would actually, if she distracted herself with something else. Let's say, for example, she started gambling, or so gambling, or use any other substances. You can see how this will also be escalated to become a problem, right? So the use of maladaptive coping strategies to solve a problem that hasn't been solved is really a problem itself. And when I'm saying this, I don't mean that it's not healthy. Actually, it is healthy to engage in, to try to cheer yourself up, or to, whenever in anxiety, you have to do the healthy mechanism. But when you're doing a maladapt, when you're doing something that can be risky, to develop a repetitive pattern, and I'll show you why in a few slides. This is a problem, right? So it would shift the problem just from one to another, and also the original problem is still there, which is obviously anxiety. We're going to come back to this one later on in the treatment. So this is one case. Okay, so this is I brought this case because of the substance use and the relationship to the maladaptive like psychological feelings. Now there's another case. And also, it's a real life case I saw in my practice within the last year. So, Mr. H, a 22-year-old man, university student, lives at home. He lives with his parents and siblings. A few years ago, he struggled with cannabis, but he was able to quit. Like, it was a short period of time. He didn't need actually to go to treatment or anything like that. But it just shows you the tendency of the use of substances / behavior for to cope with certain feelings. Okay. And then his parents, so this is when I'm usually an adult psychiatrist, so I usually see the individual by himself come to my clinic. But in this case, his mother in particularly was with him, and she complained that he constantly bothered his siblings, particularly his brothers, and this has not been ongoing since his childhood to indicate something like conduct disorder or anything like that. No, it was something fairly new, so over the last several years. He had also he had also complained of a lot of mood changes, but when I spoke to him in privately or by himself, he did tell me something that was interesting. So he told me that his mother treat him differently than his older brother. So he'll always see his mother spending times and times with his older brother, talking to him, asking for his opinion, and even like so Mr. H himself, when he confronted his mother, and he told her, like, come on, I'm seeing a different in the way you deal with us here with my older brother than me. And she told him that he's my oldest son. I love him more. So going more into like details of what he's been struggling. So I asked him, what else do you want me to help you with? And he told me that he's been complaining of or engaging into a lot of frequent masturbation. Therefore, that he's not able to sleep without it. He fairly told me that he lost control over it. So he do it over and over again. But there's also the special part of it, like he feels guilty about it. He thinks it's haram, it's affecting him, and he doesn't want to depend on it to go to sleep. He actually developed, as I mentioned, had mild depressive symptoms. The last quote here I mentioned, it comforted me So this is when I asked him, like, what does it really mean? What do you really like about it? What do you really like about like the masturbation? What does it mean to you, the personal meaning? And he tells me that it comforts me. So I think when you read the whole scenario, I think you don't need it to be a psychiatrist or psychologist to understand how his behavior, especially the masturbation, is linked to a maladaptive coping strategy for psychological stress, right? But it's not really. I just have to point out that's not really organized in real life. So this is and it's not going to be even that clear to the personal self, to anybody. Like even when we engage in, even myself, when I engage in a different and I want to understand, it won't be so clear. So that's when it comes with, that's the helpful of a therapist, where he can ask the right questions, help the patient also reflect of what's going on, understanding the relationship between the past, the current stressors, and the meaning of his current behavior. So it is all linked. So obviously there is a personal meaning here for this chronic or frequent masturbation, as it relates to how he sees a different in how is his mother treating him different between him and his brother, and that's affecting him, and that's his way of actually expressing his comfort, because he's not getting that comfort from his own mother. All right. Again, I'm going to come back to this, touch on it on the end of when we talk about treatment. Okay. So in general, when you want to define an addiction, addiction comes from a Latin word that originally means to be enslaved by something or bound to something. But a more scientific addiction, this is coming from the American Society of Addiction Medicine. And addiction in general, I'm talking, it's a primary chronic disease of the brain, reward, motivation, memory, and related circuit. Okay, so it is really a brain disease, and I'm going to tell you more about it in a bit. So I'm going to just change here. Okay, so what is addiction in general? These slides are actually prepared by Dr. Malik, Dr. Feel Malik. So it's a long-term disease of the brain, and it changes occur. So there's changes that occur in the brain, actually structurally and functionally. So even structurally, it can cause, and especially this is very specific to the substance as well. But the good news is, I just thought, because I worry when I talk about this, I give the bad, like a bad impression that a person with an addiction is doomed, especially that we might be addicted to some say or another. It's almost always reversible. Reversible meaning that can be changed. It can cause several dysfunction in multiple areas of the brain. Again, we'll talk about it in a bit. These dysfunctions can lead to biological, psychological, social, and spiritual manifestations. So these are the effect of the engagement in an addiction behavior or a substance, either biological, by health, psychological, mental illness, social, interfere with the occupational, educational, relationship, and spiritual. Obviously, the person guilt and the person feeling how it relates to pleasing Allah, or doing good, or doing sense. The substance or behavior start off as rewarding, absolutely. So that there's a high from it, but with a repetitive use, they will lead always to psychological and physical. So this is important to differentiate the psychological and physical dependence. So there, almost all of the behaviors, all the substances we call psychological behaviors. The physical dependence can occur with certain substances, just like alcohol and opioid. Like any other long-term. So this is a key thing about addiction. When we talk about cycle of decline and improvement, it's just a chronic relapse and illness. So it gets better than sometimes in your life, but and it gets worse. So because some people feel, okay, once you get treated, you're cured for the rest of your life, and the person have no excuse for coming back. Just like the diabetes, like the hypertension, like any chronic long-term disease, it has a period of cycling, improvement and decline. Long-term treatment is needed due to change in the brain. That's absolutely true. All right. Okay. So this is just a general structure. I just wanted to show you that in terms of addiction, obviously we have substance use disorder and non-substance use disorder. And even within non-substance use disorder, this is one only classification. There's several classifications. There's gambling, and then there's a technology problem, which is like the gaming, internet, emailing. Sexual buying, pyromania, which is a repetitive intentional fire setting. Kleptomania is a repetitive stealing. And then, so these are, I put it in one box because usually these are have the forensic implications. The other one, like it can lead to problem with the law even. The other one, exercising been also defined like, or then there's a research group working on it to define it, to understand how they impacted it. Repetitive eating, tanning, hair pulling, and skin picking. So the pyromania, kleptomania, hair pulling, and skin picking. So this has been moving from one, like from one category. As we understand more about it, we try, because people have defined it as a problem with impulses. People have defined it as a problem with addiction or problem with anxiety. It's probably all of the above. It's again, it's the biopsychosocial aspect of it. So it could be having a behavioral part, which can when you repeat it, you actually influence a neural pathway, a biological neural pathway. It has a psychological meaning of it. Maybe you're trying to treat an anxiety that's untreated, or trying to comfort yourself with social stresses that you try. So this is, again, I wouldn't focus very much about how it classifies. I just wanted you in general to understand. The gambling, only the gambling is identified in what we call the DSM-5, the Diagnostic Statistical Manual. This is like the guide that we use to follow the criteria. But for sure, like as you can see with Mr. H, there is a sexual problem, and he identified a sexual, so we cannot just ignore it. Oh, it's not in the book yet. Come back a few years later when we add it. It doesn't work like that. We definitely treat it in case by case. When we just like if the behavior has engaged into a repetitive cycle enough to affect the person's life, we just have to address it. Regardless. But the diagnostic or how it define it just depends on how much research is out there. And obviously, they're starting to fund in this area, but before it was not, and that's explains why we don't have enough of information or been recognized in the guide or not. Okay. All right. So substances versus addictive behavior. You have to need to the both substances and the behavior in general, including gambling, can affect the brain in a similar way. Both can lead to addictive disorder, absolutely. And neuroimaging findings, so the MRI, the CT scan, all the imaging that we have for the brain have indicated that they have very similar response to natural and the addiction response, to addictive cues. I mean, sorry. And they share similar clinical symptoms, specifically when you lose control or the craving or the withdrawal. They would be surprised, oh, there's a withdrawal even with addictive behavior. Absolutely. So we saw Mr. H, how he referred, I cannot sleep without it. So that's a withdrawal symptoms. We will see it later. So withdrawal can be very specific to certain substances because of how a substance can make you feel. And then if you stop it, all of a sudden, you get exactly the opposite. In terms of the addiction, usually they have, when you stop from gambling, you stop from sexual, there's a certain set of withdrawal symptoms. You will not be comfortable. Usually you become irritable, you become agitated, you can't focus, you can't relax. So this is a generic symptom, like we said with all the behavior. And they all can lead to negative emotion, absolutely, as a part of the withdrawal. What's interesting, because when I do this talk in a Muslim conference like this one, a lot that combine substances and one very common behavior, al-khamr wal-maisir. So al-khamr, which is alcohol, and al-maisir, which is a gambling. And it's combined it, and there's one specific ayah that's combined that they both have benefit, but have also negative effect, and their negative effect more than this. So I don't think it's a coincidence that both have mentioned in the same ayah repeatedly. It's just combining both types of addictive disorder. That was amazing, and that happened before 1400 years ago. So I found this is that was and right now we just realized about the same with the neuroimaging finding. We just realized that they both can affect the brain the same way, can create a neural pathway, a maladaptive neural pathway for both people who have problem with substances or behavior addiction. All right, I think this is a time to poll questions. So the question is, what is the least relevant symptoms of sex addiction? Is it A, the number of times the behavior has been done over the last year? Or is it B, the behavior become the focus of the person, focus and attention? Frequent family conflict because of the behavior. The person becomes irritable when it has been a while not doing the behavior. Which one do you think it's the least important for a clinician to define?
Salam, Dr. Hassan. If I can just briefly interject, if it's possible to just slow down a little bit your speech so that
Absolutely,
yeah, the
absolutely. Yeah.
closed captioning can cap. Jazakallah khair.
So, Dr. Hassan, perhaps we can ask people to post in the chat function their answer to this one, just because
Sure.
I do have the other poll questions here, but I don't see that one. So many people are saying, just to read to you, many people are saying A for that question. There is a C, but lots of A's, some D's coming up, some D's are coming
Okay.
up. The majority is A and C though, from what I can see.
Okay, very good. Yeah, that's good. You're right on the spot. So A is a correct answer where the number of times. I just put this question because a lot of people think that, oh, it depends on how much I engage in the behavior, the amount of time, and the repetitive. This is indicate, oh, if I'm drinking that much, that means I'm definitely addicted. But if I drink that much, I'm not. Or the same thing on the sex addiction. That number is the key thing. It's not usually like in nothing in the criteria as a clinician, doctors, physician, or psychiatrist we use as a number. We really define a problem as how much that behavior or that substances has affected the person's life, right? How much it interfered with relationship, how much it interfered with your work or with schooling, right? How much it causes mental health problem, depression and anxiety, ability to lose control. I'm not going to say this is not important, the number, but actually it's yeah, it is important. It's really very much correlated. So if you are engaging in repetitive times like that with the case example I brought you, a lot of times you usually correlate that the problem is getting bigger and getting out of control. But it's the least. Basically, what's important to me is to focus on the family conflict. What is there in withdrawal symptoms? Like this is what D is asking about. And B, is it become the focus? Yeah, absolutely. So when you appear, this is what we call craving, basically. It's on the person's mind all the time. And you can imagine how this can interfere with a lot of productivity or even ability to focus on other pleasurable activity or healthy coping mechanism if there's a stress going on. Yeah. Okay. So Ibrahim, feel free to remind me again to slow down. Okay. So this.
I'm good, thank you.
All right. Okay. So there's 4 C's of addiction. So a lot of people say, okay, but I have this habit. I don't know. Is it an addiction part of that? Okay. Well, so obviously to like if there is a problem that's been affecting the person individual, always encourage a person to come for an assessment, whether it's a psychiatrist or a clinician, because it's always helpful. Always helpful, at least to get a reflect some part, reassure some part. It doesn't have to you go inside and you get out of the diagnosis. I always tend to be in the neutral part and try to give an unbiased assessment, because people worry that they go inside there and leave with a label. That's not the case. But in general, we look into 4 C's. They start with C's. Basically, if you want to know, is it more an addiction part than a habit? The first one is C for craving. So what is a craving? The craving is the urge that you get, just like what I talked about before. Like you have an urge that whether when you're using or especially when you're not using, it become an urge. Like there's a tendency. And this craving can be triggered specifically about our talk today. Can be triggered very much for if the person is used to engage in that behavior or that substances after certain stressors, right? So whenever he feel anxious, he tend to think already about gambling as a way of escape. So this is what craving is. And the other C is for losing control. So losing control. So basically, they cannot stop. Just like what our case in the beginning, they cannot stop. So she couldn't stop using the sleeping medication, and he couldn't stop masturbating, and that become out of control. Compulsion, it become the center of focus of life. So I've seen people For example, people addicted to hookah or shisha. So when they I've seen people like if they're traveling or they're going away when we used to travel, and all this. So when you used to go away, they will make sure they either take their shisha with them or the hookah with them, or if usually they're worried about the customs and whatnot, they make sure that the country they're going to and has the shisha that has nicotine. So that's become the focus of the person. They're planning their life around it, right? And it can be applicable as well to behaviors. And the other C is continue. So the person continue to use. That's what we usually do. Bring the attention to the family and friends. They continue to use despite the alcohol has caused problem with the liver, but the doctor told him to stop, but he continued to use. They continue to use despite that. This gambling have made him lose a lot of money and they're bankrupt. Despite relationships, school fare, all of that. So it doesn't mean that this person is in denial. It just it shows you how much the person is dependent on it, right? It's really like it's have affected a lot of biological aspect, neural pathway in the brain actually have changed, and psychological. This person have no other way of dealing with that stress or that social stress beside this kind of engaging in this kind of behavior or substances. Yeah. So this is usually what you if 4 of these C's, that means okay, I'm more on the addictive side or more. Then it's just a habit. So they propose a characteristic or features of how you define addiction behavior in general. Because there's I think we will talk on particularly at the end. I'll present some of the criteria about the gaming addiction or gaming problems, but usually it's more or less again within the same 4 C. So one is obsessing over the object. So this again become like compulsion is becoming the focus. Seeking out and engaging in the behavior even though it's causing harm, so the continuing use. Compulsively engaging in activity, performing the activity over and over again, even if he does not want, and find it difficult to stop, so losing control. Withdrawal symptoms. So what the withdrawal symptoms is when when you try to stop it or when you're forced to stop the behavior or the substances, you get we're talking in this case about the behavior. So you get a withdrawal symptoms. As I mentioned earlier, usually withdrawal symptoms is very specific to substances. For example, because alcohol is so in general, there's downer and there's upper, we call it. So like an alcohol, a sleeping medication brings the person down when they're under the influence. When you stop it, the opposite happens. So the body reacts because the sedative that you're given to it stops. And it will create its own sedative, but it will take some time. So if you stop it all of a sudden, you create withdrawal symptoms, and you see the uppers for in case of the alcohol or the sleeping medication. So what is the upper? The patient will become very anxious, they cannot sleep, they might throw up, and in some cases it can be very dangerous, like they have seizures. For the behavior, usually, I said there's no specific thing, but there's a general thing. So the person become irritable, craving, they have restless depression. They might feel a lot of the symptoms that they were trying to cover up. So they might not feel in that case for the case we discussed earlier, they're not going to feel loved for that. He actually, after engaging in treatment, he told me, I'm trying to stop, but I don't feel loved anymore. I don't feel uncomfortable anymore. Okay, and then losing control. The person does not appear to have control when or how much when he will continue the behavior. Person often deny the problem resulting from his engagement in the behavior. Very, very common in the beginning, especially with gambling. Person hide the behavior from family and friends when they mention it, and then there's a depression also. This is specifically when they become out of control and there's consequences. All right. So I wanted you to. I mentioned that there's an internet gaming specific side. So because that was general, if you take a look at that, how it applied to a specific problem, which is like the internet gaming, you can see that if a person has the internet gaming, which is very, very common now these days, there's a preoccupation of internet gaming. So he think about gaming activity, anticipate when he's gonna play next, become dominant in his life. They have definitely withdrawal symptoms. Tolerance, so they always have to increase the amount of time they engage to help to feel exactly the same feeling that they're comfortable or any feeling that they're trying to reach or trying to cope with. Unsuccessful attempt to control the internet gaming, losing interest in previous hobby and turn. This is a big part of addiction. That because this, I'll show you. There's the new behavior that the person become used to will be the source of. If I want to scientifically speak about it, dopamine. Dopamine is, this is a chemical I'm going to mention it engaging to the pleasurable activity. So any other things will be very much less interested. Talking to my cousin is not, playing outside with my bike is not going to be very helpful. Going to Canada Wonderland, it's not going to be, all of this stuff is not going to be interested anymore. All right. Continue excessive use of internet gaming despite knowledge of psychosocial problem. Has deceived family member, yes. Use of internet game to escape and relieve negative mode. This has become actually more and more we're aware. So like this is what relates to what we are talking mainly about here, which is using a behavior to cope with a negative feeling. That's when it become a problem, especially when you engage into a behavior that's not really healthy, and you specifically become, and afterwards you lose control over it and it lead to a problem. You're moving basically the problem from one to another. Has jeopardized a lost significant relationship with educational period of opportunity because of participation? Absolutely, it did happen. Actually, there's multiple stories from the past in this. I can actually just tell you that there's actually been deaths involved with internet gaming. I don't know if you heard, but there's a couple, I think they're from Korea, where they were engaging in a lot of internet gaming, and they neglected the health of their infant until it died, and they are actually criminally charged for that. That was like a big story, and it brought the attention to a lot of the scientific media back then. But yeah, so I wanted you just to see how I mentioned the criteria of the general addictive behavior, and now the specific. So you can specify this to the sexual engagement, to anything other behavior. Or if it's easier, we can always go to the general forces. But this is what we use to indicate, okay, if this has become a problem in a person's life or not, right? All right, okay. So I kind of touched on it, but let me see, and maybe Arfin or Ibrahim help me out what the answer is here. So what would you say? Does a person, or let's say a person who had a gambling problem, but he stopped now for 11 months. Now this person passes by a casino and he see a picture for blackjack. Is it this? Oh, okay, you posted the, okay, great. And then you see, how is it could be compared to a person who never gambled? Are the brain responses going to be similar? Is it true? Yes or false? No. So now he's 11 months sober. That's a long time, almost a year. All right, so do you have the results? Okay, you're right on this. Okay, good, great. That's exactly true. So more 89% false. No, they're not going to be the same. Exactly. Because even if it's 11 months, even if it might be even longer, it's not going to be the same. There is things in the brain that happens that will activate craving for it and urge it. It does not mean that this person is weak, or does not mean that this person is doomed, that they will go back and they will engage in that behavior. It just means that the response, the new response is different. It also reflects to me, this is a point of reflection, how the powerful of prevention is stronger than treatment. So this is a general rule that we have in medicine. Prevention is always better than treatment. That is true, and this is kind of also one of the psychology of Islam. Also, that they try to set certain rules. Maybe some of this seems, other people say, "Oh, it's so harsh at this," because they're trying to prevent the stuff. Because once it happened, it can be difficult, but it's not impossible. It's not impossible. This person can have a completely normal life afterward. But there's things that happen in the brain. So I kind of mentioned the word dopamine before, right? So dopamine It's not the only neurotransmitter or chemical in the brain that's been secreted when we engage in an addictive substance or behavior, but it's one of the main ones, because this is the one where we get pleasure. One way or another, all the substances, all the addictive behavior will release the dopamine. So someone can think, oh, so that's easy. So maybe scientists should get together and create something for the dopamine, and that's it. We will treat addiction. No, that's not really how it works, because everybody is different. Everybody is using that behavior or that substances for a different reason. Okay? So I could be an alcoholic, but I'm not really trying. I don't care about the pleasure of it. I don't give up the buzz or the high that gets from the alcohol. I'm most likely, I like that when I drink the alcohol, I'm able to socially engage because I have a social anxiety that was not treated before. So that means the dopamine is not the case here. It's something else, and usually the anxiety is related to something called serotonin and norepinephrine. So this is when we talk about chemical, not just. When I say it, when I talk about this biological aspect, people say, "Oh, is this the only part?" No, obviously there's a psychological piece of it. There's a social piece of it. So that's why I'm interested in the biological piece, psychological, and the social piece. But dopamine is an important part. Eventually, even when I drink alcohol as a social lubricant, like to say, and I want to engage, the dopamine gets secreted. Okay, so why is this important? I'll explain to you for something that we really engage in everyday life, which is eating. Okay, let's say after you finish this conference and you finish from my boring talk and you want to have a tasty burger, and you did get a tasty burger, you got it delivered hopefully, and then you ate that burger and it was like it hit the spot that they say. There will be a dopamine secreted that time. And then by the dopamine usually equal to rewarding, and you get rewarded for that. If you really liked that burger from that joint, from that delivery, from that time, you will most likely have the burger again. You will most likely ask for it again, and you will engage in it again. How the repetition of this that can lead to a problem or not, but that's similar to what happens with any substance or behavior. The big difference here, what do you think? So I kind of gave you a hint by this slide. See how bold it is, the dopamine and the reward? The dopamine is created from like a cigarette, or when you play or you win a 20 grand from blackjack or anything like that. It's not the same as when you eat that burger. It's hugely increased, and that means that the reward is increased, and that means possibly that they engage in the more behavior and the substances will be increased, and that's when it becomes a problem. And then when you engage in it, you're creating a different neural pathway. So this is kind of a way of understanding it. What happens into a chemical product? Can I touch on it as well? So again, when you engage in any addiction of substances, there is a dopamine secreted. That's usually equivalent to feeling rewarded. That dopamine, like I mentioned before, I think in Mr. On one of the criteria, yeah, that he would not, or he or she would not seek another pleasurable activity. It's just because that amount of the dopamine will be secreted. Everything else that even when they used to engage in it will not matter. So again, all the pleasurable activity will be the exercise, the amount of dopamine secreted in that pleasurable activity, even the person is used to it in the past, is not going to be equal. So the person will not, so less seeking it. So it'll be dependent on that new behavior or the new substance that is discovered. Okay. And as a result, the body, Allah has put in our body a lot of anti-addiction systems, I would say, because the dopamine receptor that it will start to decrease in time. This is a way of like disengaging you into the repetitive. But when we have less of the dopamine receptor, also there's less enjoyment from other things. That's another reason why we're not engaged in the other thing, and then they will get depressed. And they might feel that they need to keep doing the drug to feel pleasure. Yeah, so they will bring it up, and then they will increase in demand. So if I'm finding, because the dopamine will be secreted, so that the cigarette I got It was not as pleasure when the first time I hit it. Really, I had so much fun when I had that first cigarette. The second one or the third, or maybe it usually doesn't come on the second. It usually come after a while. After the seven, it doesn't bring you anymore, so you have to increase it. 2 cigarettes, or the amount is being increased, and that's called tolerance, right? Same thing apply for alcohol. So it starts with 1 glass, and then end up, oh, it's like a 1 bottle of wine a day, and it's still not enough. In that period, usually in that period, the person is not even looking for the pleasure; it's just trying to maintain normality. And the same thing applies for the behavior. So it starts with one, and then you engage more and more and more. Okay, so these pictures, please don't mind the letter at the end, because this is I've taken it from an article of mine. It's under review right now. What I'm trying, and there's a, like, you see that there's a different brain structure here. I'm just I want to try to pass on the point of what happens to the brain function, because there is, I mentioned neuropathy, this word before, and I mentioned there's biological changes. So what are you talking about, the biological changes? So that, remember that picture with the burger, when you just ate the burger, the brain didn't just release the dopamine and you felt reward and that's it. It really condition or record everything going around. Where were you? Was there a background music or something going on? What feeling did you have, and what before, like maybe hunger, and then no hunger or satisfied after, or maybe I was very anxious, and then when I ate the burger, I'm not that anxious anymore. That could happen. All of this recorded in the brain, right? So here they see that all the errors. So the brain's trying to tell, okay, hey, remember this, because that negative feeling that we felt in there before, you had a positive feeling. So trying to, it's a way of engaging more to avoid any of that negative feeling. So when that person get exposed again to,
Hassan, sorry to interrupt again. If it's possible, just to slow down a little bit more.
Absolutely.
Yeah, just for the close.
So yeah, when I get excited about the point, I try to usually no problem. Okay, so what I'm trying in this picture, the woman holding her head, this is I'm just trying to do a sign of stress. The bottle is obviously alcohol, but also there's a PlayStation over there. All right, so when that person engaged in 1 or 2 or 3 behavior, but then try to stop because it's not good. This behavior is not good anymore, whether it's any behavior. But then when they get exposed to either the feeling that trigger the use of the substance or the behavior, which is the stress, resembled here in the stress, or the substance itself, or the behavior itself, whether it's the PlayStation or the brain, they can see now the brain already sent a lot of messages. Hey, come on, you can try to, you have to use like a lot of message and a lot of urge. This is when the urge and the craving happens. And this is why it's important to when I see an individual with a problem with an addiction, any addiction, is literally what time is usually you get the craving, because this is where, and it can be multiple times. It could be stress that they indicate, and it could be, I work in a bar, so I see this whenever I see a drink, I have to drink because I see, or I go out with my friends, and whenever I see them smoking, this is I heard it a lot. When I say whenever I see smoke, it triggers me right away, because the sight of the smoking, the smell of it, all of that trigger, and this is what happened in the brain function. So there's a lot of errors that it goes to the memory area, it goes to the emotional area. It's just trying to get you to get you actually feel better. It's trying to get you, but maybe it gets triggers in the wrong time. So what I mean by that is, after a while, everybody, like the individuals with a problem with addiction with any substance or behavior, they are aware. They are aware of the problems when it become a problem. They're aware that it's started into anything like that. So they're aware. So when they try to stop, it says the internet connection is unstable. So please let me know if something happened. So if when they try to stop, the purple area here, which is short for ACC, anterior cingulate cortex, and the PFC, the blue one next to it, prefrontal cortex. This is the area in our brain here responsible for saying no. This is where the decision, we can make a decision. The decision, the ability to counsel ourselves or to guide ourselves and to say, no, the effect of this is more than the positive of it, get interrupted when the person get exposed to the stress or to the trigger. Okay, so the person, when they get exposed to it, it's very strong, so that it is very strong, that all the memory, the pleasurable things is much more strong. It works by itself, and then the signals that come in from the prefrontal cortex or the area of the brain which is responsible for telling us no, they get interrupted. I know that, again, it might seem bad news, but you know, the good news, I'm just going to say it right now. This can be reversible. This can be fixed. This can be trained, actually. You have to train yourself again to evaluate in the negative. That's why I always engage my patients into remembering, why are you doing this? Why is it important for you to stop? Why is it important for you to, so, because reminding yourself that constantly, especially at the time when we're craving, it makes the signal that comes from the blue and the purple area of the brain, which is responsible for actually planning and organizing and executing the decision, much more stronger. Okay.
Okay, Hassan, we'll have to move pretty soon to the Q&A. It's actually set for 1:40.
All right. Oh wow. Okay, the time flies. I don't know. I realized. Okay. All right. Okay. So, when you did your addiction get you involved in a vicious cycle. So person starts usually here with binge drinking, and then it goes with a withdrawal. So if you try to stop it, you go in a withdrawal. Sometimes you go back to binge drinking to avoid the withdrawal, and sometimes even if you avoid for it from a very, like if you've been away from it long time, there's a craving for it that trigger you to preoccupation. This is the psychological part we're talking about. So I'll leave the maybe, I think maybe the session is recorded, so you can take a look at this later. This is basically tell you it's a chronic disease. Here I compared it to diabetes type 2. They both have the same genetic risk, both have the same risk to return to the disease, both have the initial choices. So like this is just for you to reflect, how is it a brain disease? Okay. Just by answering, maybe because of the poll, it really takes time. So do you think the behavior addiction usually develops quickly? Is it true or false? You can just type A or B. Oh, okay. So you can just tell me what's been answered so far. Yeah. Okay. Perfect. Okay. Develop quickly. Is it true? No, it's actually false. This is the more false. So it's a process. Addiction is a process. Like I mentioned, it's not from one time you engage in that behavior and that's you do. Usually you have to repeat it. The neural pathway that I said that you saw that error, it get created whenever you do it, and then so the brain learns. Yes, I learned that when I do the masturbation, it comforts me and it really helped me relieve that feeling of loneliness. It helped me relieve that feeling of stress. It helps me. So the brain learns over time. So, and same thing with the substances. All right. Most individuals exposed to addictive substance or behavior struggle with addiction. What do you think? True or false? Okay, so the majority is false. No, yeah, that's right. That's false. It's the most, only minority of individual. I'm just trying to get it next slide because it has only minority of individual. Yeah, it has it. So addiction is a process, as I mentioned. It will not be overnight. It will happen even with the most addictive substances, nicotine or heroin. It will take some time to get addicted to it. And only minority of people become addicted. And it has something to do with maladaptive coping mechanism. What are the biological aspects? So the genetic so there's something called epigenetics, meaning top of genetics. So basically, if I smoke, I'll create a genetic that pass on to my next generation, and that will make them more at risk for certain substances. Not by it will not force them to go and buy the substance from the dealer and whatnot, obviously, but it will force them to change how much they will like it, how much it will change into their neural pathway in the brain. Environmental, social contributed, obviously, who you hang out with, what is your values of this, is it acceptable, is it not acceptable, is it accessible, is it not accessible, all that play into it. So there's a psychological part and social part. Biological parts of the family history, and we talked about it, early drug exposure, even so. If you get exposed to it early, especially in the adolescent, this is a time of the person's life where they start to still exploring. They have poor skills of handling emotions. So imagine you're put in a drug or a substance that day, so you early teaching your brain of how to handle emotion in a negative way, right? Poor support, obviously, normative attitude. Normative attitude is meaning how it become models by parents. And then there's certain mental illness. I'm just going to show you this because it just summarizes it all. So substance use disorder can lead to depression and anxiety, just like we saw with the case in front. But it also can lead to, we see a lot of people with substance use that have a behavior addiction. And the three of them can lead all to the problem I mentioned earlier. Health problem, emotional problem. So basically the negative effect of it. So it's very much interrelated, and it's not one-way street. It's not like I'm always going to be depressed because I'm definitely have something wrong with my brain because I'm addicted to something. No, it's possibly that you engage into this because you're trying to relieve your mood and anxiety. But it's possible that you just, the circumstances have exposed you to that substances or to that behavior, and you engaged enough time in it until a depression or an anxiety happens afterwards. So it doesn't mean necessarily that the presence of a behavior means there's something hidden. It could be, yeah, absolutely, but it's not necessary. All right, so this is one study that's been done in 2014, and I just basically summarize things that have been told. So why would some people with depression have behavior addiction and why not? Even if it's the same people, like some people with depression get engaged into behavior addiction, but they didn't get addicted to it. So they found that there's certain coping mechanisms. So the people who try to distract themselves from the problem, escape from reality, avoid certain feelings such as loneliness or annoying duties, have more at risk, because obviously they found that this behavior can relieve these symptoms, and this is when it becomes a problem, because this behavior itself, it can be problematic, right? I'm not talking about healthy. I'm not talking about using like going for walks or talking to people or whenever you feel stressed. I'm talking about engaging into gambling. I'm talking about smoking, going to the bar. These are the stuff when you use it in a difficult time. This is when it becomes a problem. So that's why it's actually, if you look at the guideline for the Canadian specifically guideline, it tells you not to drink whenever you're stressed out. So this is where it comes in. It doesn't want, they don't want to teach you the brain to use it specifically. It will relieve some certain stresses at that time. I'm not going to go into this because I talked about it every time. So you can imagine how the possible consequences of addiction. It leads to all of that, especially here, the lack of connection with God and Islam is something I hear a lot on my patients who are Muslims. Specifically to behavior addiction, it will lead to sedentary lifestyle, lack of social engagement, problem with concentration and attention, increasing aggression and violence. We see this a lot. Started not to come a lot specifically with video games as well. So I'm just going to stick a little bit here. I don't know if a lot of the audience are clinician or not, but for the clinician, this is like, because I get a lot of questions specifically after my talk about how do you approach usually behavior addiction, imams maybe. So there's three things I look into. First, how motivated is the person? If the person is motivated, that's good. And then we move to the second one. What is the personal meaning of the behavior? It's like I asked the case I presented in the beginning. What is the meaning to you? So basically, in other words, what do you like about it? And then the level of impulse. Usually the level of impulse is like how much you can control over it. The third one, it will really help a lot if a medication is being needed or an inpatient rehab is needed. If the first one is not, if the answer is no, or if the person is not motivated, I usually don't proceed into these. It means we have to stick with this, because if the person is not motivated, like when the parents of or the family are forcing, there's little to be done. Person has to engage in, but that means, oh, okay, we leave him alone until he gets motivated. There's a way to get him more motivated. So that means when he's not motivated, the what he likes about it is more than what he dislike. And this is where our job is, to bring the reflection to. There's actually a therapy, it's called motivation interviewing, that it's all focused is to make the likeness is less. So there's more damages, the more awareness of what they don't like about it than they like. And that's what we create a media motivation. And that brings me to this, because I also get asked a lot about it. So this is a decision and balance. You can print this, you can find it actually online. And this is for a person who are still, okay, I know it's a problem, or I know it's created some problems with my family, but I'm not really sure if I should change or not. Okay, well, I encourage you to do this and write your own reason. Here in the top row is if you want to change. What do you want to? The reason is the good stuff about reason to change, and on the left, not good reason about changing. And in the bottom, if you keep things of and then what would happen? So so this, when they see it about like on a sort of scale, that will engage them. Okay, I can see if I'm engaging, if I'm changing, I have this, and this. If I did engage, I might lose my my friends. So this is what also help the clinician, or help also the person to what focus on. So if what's an obstacle for me to proceed forward is a social. This is maybe I should find an alternative for other social participation. Yeah.
Doctor, we're quickly getting to 2 o'clock, and I do see some questions here by some of the attendees.
Sure.
Is it okay if we go to the question and answer?
Sure. Well, yeah, we will get into the treatment options. So yeah, I'm happy to answer. So maybe we can get to the question now. I apologize for being.
It's all good. It's very informative. Okay, so the first question I see here is there data about the status of substance use and addiction among the Muslim community?
A good question. Very, very little. We did last year, or this year actually, we published a study, like a community outreach support for going to mosque, going to the Muslim community in Canada. Try to do this some sort of very simple, a more simpler model of awareness about addiction. And when we got into the writing area, we found very little data. And that's we did another. We're doing actually another study. So this is one of the posters. They're going to be in tomorrow in the poster sessions. We did a small review in rates of substances in the U.S. because that's the available data. Unfortunately, we do not have it in Canada. The rates are like in general, people who did admit with substance use is self-reported, so there might be a little bit of bias in reporting. The rates are in caution, they're less than the general scheme. So when we compared it to the general population, they're less. But the reason for the rate of utilization of treatment are pretty low, and the reason is different from the general population. So the reason we're focused on, or for people who get actually engaged into treatment, they were more focused into the social aspect, how it did affect their family. So they went to family services. So it's really a good question, and it brings up that we need definitely more research into this one because the rates are not quite so clear. Even in the countries where Muslim majority, we have little of this. This is really a big taboo that people are trying to avoid. But hopefully in the next 5 years we will have more data because it doesn't mean that we don't have data that the problem doesn't exist. I definitely, as a physician, see it all the time into my practice. So I know it's out there. So yeah.
Perfect. The other question I have here is how can imams support individuals in the Muslim community who are struggling with addiction?
Okay, so first of all, like talk like this or other talks or even education ourselves about what is going on. This is like, I think this is the first step for imams, because we need to know that, for example, like I mentioned earlier, there is some harm if certain substance stops suddenly. For example, alcohol or opioid. This can be actually fatal, like it can lead to death if certain. So this awareness of what's the effect of it is pretty powerful. But I'm gonna actually it just brings me, because it's always a common question. Is to, yeah, about this life. How can I help someone with addiction? So this is in general, not just imam, but a lot of them with even with their family members. So raise your concern gently. I want you to be really persistent, but do not argue with them. Okay, so if you find yourself getting into the argument, take a pause, maybe leave it for an hour or two, day or two, a week or two, and then come back to it. So be persistent, but don't ignore it. Okay, and no one ever like to be judged. No one like, oh, you're an addict, you're just an addict, like everybody like certain and certain. No, nobody like to be compared, and nobody want to be judged. So avoid. So you can use words like there's a lot of people with a problem. So everyone has had a problem. So that's more gentle, I would say. Yeah, encourage change, express confidence, reflect the positive, even small success. Remember that day that they didn't use, and to you is going to be very small, but to them is huge. Okay, so you gotta reflect that. Oh, I'm very proud. This word, I'm very proud of you, and yeah, I know you can do it. Like, they are very powerful, they beyond imagination. So when they see that someone and they're actually, they love them and they care them and they believe in them, I'm motivating them. You are curious when you see this stuff. You're secreting dopamine yourself, right? So this is imams need to do that. Need to hear it's like you do more about the problems. Don't dismiss the problems. Use the spiritual aspects, all the great example we have from the Prophet Sallallahu Alaihi Wasallam, how everybody's a sinner, nobody is perfect, but the best sinners who actually can get over. So all of this is very important. When we hear this, like the imam is in support, my family is in support, and my doctor is in support. What do you need else? That's it.
That's it. All right. Another attendee here is asking, when a psychiatrist prescribes you some medication that are highly addictive, such as ADHD medication, how to get out of it, and is there an alternative? We'll also take it to 205, just so that we can, inshallah, go over a couple more questions, because there's a lot of good ones here.
Take it to, sorry, Brian.
Yeah, so we'll push the Q&A until 205. So
205, yeah.
A lot of people asking interesting questions.
Yeah, I told you this. It's not 1 hour is not enough, and like it was not enough. Usually, because, and that's why I tried to. I thought I would be enough because I made 60 minutes, 60 slide, 1 minute. Anyhow, I'm gonna stop and answer the question. Okay. So the addictive, yeah, ADHD can be sometimes problematic, but there's a lot of people who are able to get over it. So remember, if you actually have ADHD, there is actually, we have literature, we have evidence support that because of the ADHD stands for addiction deficit hyperactivity disorder. Dr. Malik, Dr. Afin, she's a child specialist. She can tell you more as an expertise into this disorder. We do have that if this disorder was not treated, it can actually lead to people to addiction. Okay, and the opposite is not true. So people feel like, oh, if I got to put in the ADHD medication, it will increase my risk to become an addict or a substance use problem or a gambler. That's not true. So with research, no, because you're treating the problem. Look at the cases we talked about it. There was a problem in the beginning that was not discovered. Then they engage into certain things and they found a relief in there. But the problem is it's a problem itself. So there's an Arabic say you move from one hole to a bigger, deeper hole. So that's exactly what it is. So yes, it can be physically dependent, but a lot of doctors are aware of it and they have a certain plan or they follow. So a very gradual discontinuation. They call it drug holiday. So they give them holidays and they don't give them the drug in the summer and the weekends. Again, Dr. Malik can speak more about it. That helps not being dependent on this medication. So I wouldn't discourage you from using. Actually, speak to your doctor. Speak about your concern. I'm worried about being addicted, and this can be for sure, inshallah, addressed.
I also had a question for you myself, actually. most of the time when you're counseling somebody that is struggling with addiction, do you insist that they attend a 12-step support group? And what are your thoughts on 12-step groups like Alcoholics Anonymous or Sexaholics Anonymous for process addiction?
Yeah, and again, I apologize about it because it's all in here. So, like one of the things that's helpful, so when you approach biopsychosocial, social, biological is the medication, and there's a psychological. There's different kind of. You see, there's CBT, psychodynamic motivation interviewing, motivation interviewing. This is the therapy we use to motivate a person to quit, even if they have partial awareness of this. This is good. And then there is the group therapy, if, for example, 12 steps. So it really focus on. So the group, the more the focus. So for example, if you have AA and you have a problem with alcohol, that would be best fit. Or if you have a problem with heroin and you go to NA, Narcotic Anonymous, that's more better. And there is 12-step for gambler. There's 12-step for sexual addiction. So they focus on the social support and peer sharing of experiences and peer confrontation with them. So when I, as a therapist, as a doctor, I confront the patient with this is usually not helpful, or not a patient, an individual with a problem. But when it comes from a peer, when you're in a group, it usually works best. And also the sharing experience. I get a lot of experience of I thought my problem was big, but when that guy talked, I really don't want to be like it. And then it encouraged him to remain in treatment. So that's another thing. And I focus on social support. Actually, I think it's a great idea, but the more it's focused, the more it helps because you feel that you're not alone and you feel that. So, with encouragement also to bring the reflection of we really in the Muslim population, we have less groups in there that's very specific. So, I would love to be, inshallah, we see in the next 5 years more alcohol, 12-step, that's specific for alcohol. Or for Muslims with alcohol, and Muslims 12-step for gambling, Muslim 12-step for everything. So you'll feel even supported by the Muslim. You're gonna talk about everything else that's you can bring it up in the generic. Yeah. So this is real. This is a true sense of social support, especially if you're feeling alone, if you're feeling lost, if you have a lot of guilt, and you hear it from a Western fellow how this has a great support. So yeah, absolutely. I think it's a great.
Mm-hmm. And it ties into a lot of questions. Actually, I was just gonna, ask you about, people are, they want to know if there's any, Muslim addiction recovery resources.
We do. So they can email me, and then I'm happy to provide. There's also a great source of is the website for the conferences is the MMAC. So I will get you, maybe Dr. Arfimalik, can you give me the exact, I think it's the exact website, and they have the one of the version of this slide, so you can have, and they have also resources specifically because it's Canadian, so we have in Canada, and they can look into it. There's my information there. There's a lot of therapists that's great. They're Muslims. They're very culturally sensitive. They can be helpful into this matter. So I just encourage Dr. Malik to give them the website exactly. Maybe she's right.
Yeah, so we'll write it down in the chat, but as Ibrahim has mentioned, a lot of the questions were about, if there's existent 12-step programs that are for Muslims, and as Dr. Hassan's kind of mentioned, we don't have those available, but we really hope that we can identify this gap and that we can address this gap. And there are therapists there who have identified if their specialty is in addiction.
I don't think we can hear you. I couldn't hear.
Same here. It wasn't too loud.
Muffled, yeah.
Mm-hmm.
Can you hear me now?
Yes.
Okay, I was just saying that the website is available, www.muslimmentalhealth.ca. It has a list of therapists who are able to provide both addictions counseling and are Muslims themselves, but unfortunately we don't have any specific to my knowledge, addictions resources that are something like 12-step groups just for Muslims in Canada. This is definitely an identified gap, and we're really hoping that us as a community can come together to develop some of these really important groups and resources.
I could actually share some resources myself, because for the past 2 years in Montreal, there has been 12-step support groups in a Muslim community center that deal with Muslims struggling with sex addiction, or mostly pornography addiction. So there are in the Montreal area. There has been some prevention works as well. I work in the field as an addictions counselor, so I get to see like a lot of efforts starting to pop up here in Montreal. But also with regards to the 12 steps, if I can just add, because a lot of times people say, and I don't know what your thoughts on this, Dr. Hassan, but people say like, is there more like a Muslim 12-step group? But if we actually take the time to look at the 12-step programs, a lot of the things are actually, all of the principles of them are really in line with Islamic principles, finding a power greater than ourselves that can, restore the person to sanity, making amends, and then, recruiting or helping other people through the 12-step, in the recovery process. I don't know what your thoughts are on this, Dr. Hassan.
Absolutely, absolutely, and this is what I actually, inshallah, expect to happen in the next one, because we have more interest in this, and we don't have to copy paste everything, because we have, inshallah, mashallah, and there's a lot of principles that help with that. For example, like I'm actually working on creating a group right now that use dhikr, or basically it's called mantra in this, but we have it actually and that for reducing the stress related to PTSD and addiction. So this is something that's been I know there's Dr. Yusra Ahmed also using some sort of thing, or another mindfulness, but specifically to treat anxiety for women. So there's a lot of stuff that can be done and we actually do it traditionally, subhanAllah, but it can be more focused into this kind of groups, so it can be condensed and traced. So absolutely, I agree with you 100%.
Yeah, and one of our attendees as well has shared that there are Muslim AA and NA, so Narcotics Anonymous, in Vancouver areas.
Okay.
So we'll be adding all these resources to the website as well, inshallah.
That's good. Yeah, that's very helpful.
Yeah, that's the Muslim Care Center based in Vancouver that's organizing these meetings. Perfect. So I think we'll have to wrap up the session and end right now. So as to allow the participants to join the next one, inshallah, which is Mental Health 101 at 2:20 p.m.
Okay, great. Thank you very much. I apologize for the delay.
Very informative, and we wish that we could have heard all of it, and that you had more time to go through all of the slides.